So on this side we have atrial fibrillation. I like to think about atrial fibrillation as multiple depolarization waves that create their own little microcircuits within the atria. The fancy word for this is reentrant electrical spiral waves. So as you can see here, there are a bunch of little different circuits and they are just looping around within each atria. They're depolarizing independently of one another. There is no synchronization of the atriomyocytes to all contract at one time. Thus, no unified contraction is the basis of atrial fibrillation. Fibrillation means to quiver. It is fibrillating because there are many different depolarizations. This one could happen first, then this one could follow, then this one could follow, this one could follow. It's not orderly and it's not synchronized. So do you think that we will have a P wave on the ECG? It won't be there at all. But why not? Remember, we only get a P wave when we have all of the atriomyocytes depolarizing simultaneously, because then we add each individual depolarization to get our mean electrical vector, which is the P wave. When the atrial depolarizations are all out of sync, we do not get the summation into one large P wave. Rather, your electrodes detect these irregular individual depolarizations that are occurring in an unsynchronized fashion. And these show up as these little baseline quiverings because it's trying to read all these different depolarizations. They're occurring at different moments in time in different directions. And that gives you a very irregular baseline. If there is no unified large electrical vector depolarization, then all we have left on our ECG are the multiple individual depolarizations that are occurring in many different directions at many different moments in time. I repeat, these atrial fibrillations are just ununified depolarizations that are not synchronized chronologically. This is represented on the ECG by a chaotic and erratic baseline, which is classically defined as irregularly irregular, with no discrete P waves in between irregularly spaced QRS complexes. So why are the QRS complexes spaced unevenly? Well, the SA node up here is not setting the intrinsic rate because there's so many random depolarizations everywhere in these atria. All of these different abnormal circuits can have different refractory periods, so you can have a random depolarization of the atrioventricular node. The AV node does not discriminate on which signal activates it. If a depolarization hits it, it's like, appreciate it, I'm going to go ahead and propagate this into the ventricles after my delay. It is basically just a first come, first served basis when the AV node has repolarized from the last time it was activated. The AV node will still be functioning normally, but the signal that it is sending down into the ventricles will vary depending on the refractory periods of the multiple micro circuits in the atria directly above it. Okay, so the varying activation of the AV node causes random intervals of the ventricular depolarizations, which shows up as randomly spaced QRX complexes. As you can see, this one is spaced like this one's a little bit longer, this one's a little bit longer, and this one is a little bit longer as well. But what about the atria? So atrial fibrillation causes the atria to just quiver because you're depolarizing that muscle a million different times in a million different directions with a bunch of little tiny different currents. You do not have a unified contraction, which means that your atria will be terrible at performing the atrial kick that is required to pump the remaining blood volume from the left atrium into the left ventricle. So what do you think might happen if your atria is just quivering instead of having a unified forceful contraction? It's just going to start pooling blood. Blood will just be hanging out in the atria, waiting to be pushed into the ventricles by the atrial kick that would normally occur in the second part of diastole. Yeah, but will this kick ever happen? No. Remember, the atria are contracting in random areas instead of all together and unified. Will this give you a risk of forming a blood clot? You bet. This blood is just sitting here very static, and when blood is very static, it likes to coagulate. Blood stasis in that left atrium is a great recipe for thrombosis. This is a huge problem for people that have AFib. In a quick review, you should know that the ECG tracing for atrial fibrillation is completely dependent upon the random depolarizations occurring in the atria. You end up with irregular rhythm because you have no unified P wave that would represent all the atriomyocytes contracting together, no isoelectric baseline because there's always some random depolarizations going on, and a variable spacing of the ventricular QRS complexes because these random depolarizations will activate the AV node at inconsistent time intervals. Okay, so we absolutely just crushed that concept behind AFib. let's go on to the next slide to see how atrial flutter is different. Alright, no playing around here. Let's just go ahead and say exactly what is causing the problems in atrial flutter. There is an abnormal, large, anatomical electrical depolarization loop in the right atrium. The wave travels up the interatrial septum, across the top of the atrial wall, down the right wall of the atrium, and finally between the tricuspid valve, fibrous ring, and the inferior vena cava. So again, up the interatrial septum, across the top of the atrial wall, down the right wall of the right atrium, and then finally between the tricuspid valve, fibrous ring, and the IVC in this region here. The depolarization is looping around this abnormal macro circuit. So large areas of the right atria are depolarized over and over again, as the current is just going to loop around just like this. Remember that this depolarization current stays in that one abnormal large circuit loop. There's only one loop. This makes perfect sense when we look at our ECG. The tracing tells you what is going on. So when you look at the ECG tracing, you see the repetitive sinusoidal sawtooth appearance of the flutter waves. And that's because every time we get these sawtooth patterns, it's just telling us that we're going through the same circuit over and over again. And that's why they all look rather similar. So atrial flutter can be a problem depending on the rate at which the AV node responds to this looped depolarization. Again, this is our AV node. So if this is going around really fast, that AV node will be stimulated every time this loops around. You must prevent that AV node from being overstimulated by giving them a beta blocker or a calcium channel blocker. This ensures that the AV node does not respond to every single stimulation that loops around the circuit if someone is atrial fluttering. Eventually, if this continues to be a problem, you can just stick a catheter in there and just ablate that. So again, you give them a beta blocker because when this electrical current is looping around just like this, you want to prevent a one-to-one transmission to that AV node. So you give them a beta blocker or a calcium channel blocker to decrease the conductance to the AV node, so that for every 2 loops, you only get 1 conductance, and therefore you want a 2-to-1 ratio where you have the atria depolarizing and then you get 1 QRS complex. Eventually, if this continues to be a problem, then we just completely ablate that. Get a big catheter and just ablate the entire circuit. Okay, the last and the most dangerous that is very important for you to know is ventricular fibrillation. If you look at the rhythm strip at the bottom of the slide, can you see any identifiable waveforms that look normal to you? No way. It just looks like I was crazy and just drawn all over the slide. It kind of looks like a mountain landscape on the ECG paper and someone drew it with a blindfold. This usually starts from ventricular tachycardia when there are a bunch of depolarizations happening so fast that you eventually get some ionic imbalances that lead to the disruption of synchronization. Essentially, we have created some multiple reentrant circuits, just like we had in atrial fibrillation, except that these are a bigger problem because we don't have that AV nodal delay to save our lives. Remember, these multiple different excitations of the ventricles are not able to coordinate themselves into a single ventricular contraction. They are way out of sync from each other. This means that ventricular myocytes cannot contract in unison to eject blood into the pulmonary artery or into the aorta. This is why you press on the patient's chest and do CPR, because your external downward pressure above the sternum serves as a replacement for the pumping action of the heart, because in ventricular fibrillation, all that's going on is that these ventricles are just quivering, just like the atria were in atrial fibrillation. You must defibrillate these patients to reset the electrical conductivity of the individual myocytes and hopefully terminate those little individual reentrant waves. So you shock them, big electrical impulse, and you can hopefully knock out these different currents and have them all repolarize at the same time, and therefore they will be beating at the same time in the future contractions.